It's now the time to introduce Daniel Staub from Switzerland. He will provide his great experience in the assessment of carotid plaque. Please, Daniel.
Thank you very much, Vito, for this kind introduction. I'm happy to give a lecture to the assessment of carotid plaques by using contrast-enhanced ultrasound. And I will start just to see on the conventional ultrasound what we are looking if you're looking at the atherosclerotic lesion. So we start to looking at early signs of intima media thickening, or we are looking at the plaques as the focal structure encroaching into the arterial lumen, or slight stenosis, and then normally doing grading of the carotid stenosis by using the hemodynamics. So what maybe is also important, not only looking at the hemodynamics, but also looking at the plaque itself, at the plaque morphology. We know there are some changes within the plaque which are making a plaque vulnerable. This is the large lipid core, the necrotic core. This is the inflammation. These are also the vessels, the neovascularization within the plaque that going into an intraplaque hemorrhage and these small ulcerations. And therefore, we can use contrast-enhanced ultrasound. And here you see at this side kind of contrast-enhanced ultrasound of the carotid artery, where you can enhance the carotid lumen, where you can delineate the endovascular border. You see also the plaque-ulceration in this example here. And if you look carefully, you can also see within the plaque some kind of vascularization called neovascularization. What we can use for contrast-enhanced ultrasound also for carotid plaque screening, and this has been shown that by using contrast-enhanced ultrasound, we can enhance the detection of carotid plaques, mostly if there are hypoechoic. And you see here in this publication a few years ago that you can increase the patient detecting atherosclerotic lesion in this group, and also within all the cardiovascular risk groups. But you can also see nicely the plaque ulceration. You have here some examples of plaque ulcerations in this patient on this side and on this side. Both you can see also here some vascularization. But what has been shown recently by Rafaelidis, that by using contrast-enhanced ultrasound, you can increase the sensitivity to detect some kind of plaque ulcerations compared to the conventional ultrasound here from 40 to over 90%, which is excellent. And I think it is a great option to see this alteration in these plaques. But which is most important, you can better do a plaque analysis by using not only the B-mode ultrasound, as you can see here, or to see the plaque echogenicity, the homogeneity and alteration in this example here, which we know that echogenicity is also important to see if a plaque is vulnerable or not. Mostly the hypoechoic lesions are more vulnerable, but you can, by using contrast-enhanced ultrasound, also this vascularization within the plaque. You see this here in this example nicely, and you can see some alteration. Normally, you look at the intraplaque neovascularization by grading the plaque or the neovascularization as absent, moderate if you only see plaque vascularization at the base or the shoulder of the plaque, or you see an extensive vascularization within the plaque core. You say this is an extensive vascularization by visual based. But you can also use some kind of a quantitative analysis. Here is an example of the U-box where you can use the enhancement over time, and you give a bolus of the contrast agent, and you look at the enhancement within the lumen compared to the enhancement within the plaque, and you can calculate the relative perfused area within the plaque and the intraplaque neovascularization surface area. And a similar kind of quantitative analysis has been done before from another group, and they have shown that this quantitative analysis correlates quite well with the visual-based analysis of intraplaque neovascularization. That we can see is this really also small vessels, and this has been shown in different studies. This is a study from Germany. They have looked at the intraplaque neovascularization in carotid stenosis that undergo carotid endarterectomy, and they compared the vascularization within the plaque with the corresponding histology, and they found a quite good correlation not only with the amount of vessels, but also with the inflammation within the plaque. And this is another group. They have looked also at the by using an automatic measurement of the intraplaque neovascularization on ultrasound compared to the histology, and they really found a good correlation between the vascularization within the plaque and the corresponding histology, so that what we see in contrast-enhanced ultrasound seems to be really these small vessels within the plaque. So we looked also at some patients with carotid lesions, over 175 patients by almost 300 carotid lesions, and we looked at the degree of stenosis and the echogenicity of the plaque, and we compared this with the neovascularization within the plaque by grading 1 to 3, and we saw that by increased grade of stenosis, there was also an increase of vascularization. You see this here, higher grade of stenosis had higher vascularization. And what you also see, and this is in line with the concept that hypoechoic lesions are more vulnerable, so that this hypoechoic lesion seems to be more vascularized than the hyperechoic ones. So different studies also have looked at the prevalence of intraplaque neovascularization and compare this with the neurological symptoms of the patients. And they all found all these studies summarized in this overview, also including our studies, that higher prevalence of intraplaque neovascularization in symptomatic compared to asymptomatic carotid stenosis were increased with an odds ratio of almost 20 But all these studies have not been are not prospective studies. There are retrospective studies. This year there was a small study looking at in a prospective design in a patient cohort with TIA patients, and they looked at if these patients have future ischemic strokes when they have more intraplaque neovascularization. And it seems that the higher intraplaque neovascularization in this cohort was significantly associated with future ischemic strokes and TIA. So I will show you some examples now how we can use this contrast-enhanced ultrasound. For example, in this patient, 76-year-old patient with transient monocular vision loss on the left side, you see the color Doppler with the plaque or the stenosis in the bifurcation or in the proximal part of the internal carotid artery. You measure the velocities. There seems not really a high grade or significant it's a little bit significant, but not, it's around 50% stenosis in this patient. And if you look by contrast-enhanced ultrasound, you see in this patient that you have a few vascularization at this part of the plaque. You see this here and here, coming from the vasa vasorum of the vessel wall on this side. And so you can use this technique also to see if maybe this is the lesion that is a vulnerable plaque, and to treat it accordingly. You can maybe decide to increase medical therapy, and you see here by using the flash that all these little vessels disappears, so that you are sure that are not artifacts, that are really contrast-enhanced microbubbles within the plaque. So I have another examples with a higher grade of stenosis. This is a 71-year-old male patient with an asymptomatic but quite progressive moderate carotid stenosis between 50 and 69% at the origin of the internal carotid artery. You see this on this side. You see this hypoechoic lesion here with the velocities, which is moderate stenosis. So if you give now the contrast-enhanced ultrasound, you see that there is an alteration in this stenosis. You see also some vascularization within the plaque. If you wait, they are coming a little bit later. And you can also quantify this vascularization by using the view box. So there is a relative perfused area, which is high and of 78%. And so you are facing an asymptomatic, moderate, hypoechoic, alterated, and extensively vascularized carotid stenosis. These are, seems, all signs of vulnerable lesion. So even there is a moderate stenosis, maybe you can discuss if this could be an indication for a prophylactic invasive carotid artery treatment. So I have another example of a 64-year-old female patient with an asymptomatic hypoic plaque at the origin of the internal carotid artery on the standard ultrasound. A sole cardiovascular risk factor. She has an elevated LDL cholesterol of 3.6. This plaque, if you see here, you can nicely see it if you give the contrast-enhanced ultrasound, and you see there is a quite vascularized this plaque. You can quantify this. You have 70% relative perfused area in these patients after giving the contrast agent. So we put this patient on a high-dose statin therapy with rosuvastatin, 20 milligrams daily, and we decreased the LDL to almost 1.4, which is excellent. And after 3 years, you see that the vascularization decreased. You can also confirm this by using this quantification of going down to 40% vascularized plaque. So you can use also contrast-enhanced ultrasound to monitor some kind of carotid plaque by looking at the neovascularization over time. There have not been so many studies looking at the use of intraplaque neovascularization, contrast-enhanced ultrasound imaging following statin therapy to do a monitoring. So they have a few small studies looking here from a Chinese group at 10 patients. They looked at 2 years follow-up with atorvastatin therapy. They also measured vascularization within the plaque, and you see there seems to be a decrease of this vascularization over time, which was significant. And another study, which was a little bit larger, they compared this with a control group, and this there was a group on atorvastatin and a control group, and they had shown that in the group with atorvastatin, the vascularization over time decreased also. If you look at the different vascularization grades group, they go from more grade 2 to more grade 1 and 0 compared to the control group where there were no so much change over time. So to conclude, we can say that the dynamic contrast enhanced ultrasound for carotid plaque can be helpful in carotid artery by looking at the delineation of the endovascular border. You maybe see more clearly the hypoechoic plaques and plaque ulceration, which is important. And not only the severity of stenosis, but also the lesion morphology seems to be important for risk stratification. Therefore, we can use contrast enhanced ultrasound to visualize and quantify intraplaque neovascularization as a surrogate marker of plaque vulnerability to optimize risk stratification of stenosis and plaques. And maybe we can also monitor therapeutic intervention. However, we have to do more studies to look at the predictive value of carotid lesion neovascularization detected by contrast enhanced ultrasound, particularly in asymptomatic carotid stenosis, if it is helpful to decide if this patient have to be treated also invasively or not. So thank you very much for your attention. I'm ready for your questions.
Thank you, Daniel. You showed us how effective can be CEUS for carotid evaluation. Since there are no questions from the audience, today is very lazy. The audience is very lazy today. I don't know why. The lectures were very interesting, but I have a curiosity and I would like to ask.
Okay.
Yeah. As you know, we are starting by some years to study the evaluation of neovascularization, also to assess the severity of the stenosis by using CEUS. But how many of the plaques that were considered stable at baseline and color Doppler were turned out to be unstable by using CEUS in your experience? Do you have a rate or an idea?
To
the ones, of the changes of the diagnosis from stable to unstable according to the presence of neovascularization by means of CEUS.
Okay, yeah. This is an interesting question. So it depends a little bit. If you look at alterations, you see not so many alterations, I have to say. So the huge alterations, there are quite an exception. The small alterations maybe are more often. And in these cases, this can help. I cannot say in how many percent, maybe 10%, it's not so small. But what you can often say is this vascularization of the plaque. So if you look at the higher or moderate vascularization, there are quite a good part of patients there. They have some kind of a vascularization, let's say 30–40%, and then these patients, maybe you can help to change the vulnerability of the stenosis, particularly in the asymptomatic patients, where you are not so sure if you have to do something, even you have high-grade stenosis. And maybe you can also say there is no vascularization, maybe a stable stenosis, and you can omit or you can have the opportunity to say no, there's no need for any intervention, which is also helpful. So exactly a percentage where we can change our decision is difficult to say.
Yeah, and that's one of the reasons, because I would like to propose to you and Dirk also to try to put together our data and to analyze retrospectively in order to really give a number, because we need to find a clinical value of what we are doing. That is clear, but is not yet proved. And what about CT and MRI? Which one do you prefer as a second ultimate imaging modality?
we preferred MRI to do in all the patients that we have to decide if we have to do an invasive therapy. We do this, and then now also we try to do also plaque morphology on MRI, looking at the intraplaque hemorrhage, which maybe it's excellent by using MRI, which is more difficult with ultrasound to see the hemorrhage part of the plaque. So we go in this direction, and then we can add all these components together to make a decision in an interdisciplinary conference.
I'm asking to you because, as you know, still the guidelines are suggesting CT as a second and ultimate imaging modality. Most probably, it is due to the widespread availability of the first and still not the widespread use of MRI. But I'm strongly quite confident that in the future, this paradigm will be changed, and we need to contribute with our results to change it. So by now, I thank really for your great lecture. I wish you a great day. I hope to see you soon.